I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about advocacy and leadership and about ISSWSH. Before I get into it, the first thing I want to make very clear, this is not meant to be any type of religious or medical advice. If you have any questions about your health, please go speak with your healthcare provider. And if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super duper excited to have on with me Sue Goldstein. Sue Goldstein is a rock star and is a huge part of ISSWSH. And I will let Sue introduce herself to the viewers and audience that may not know who she is.
Thanks, Sadaf. So as she said, my name is Sue Goldstein. I am a clinical researcher and a sexuality educator at San Diego Sexual Medicine. I'm also a past president of the International Society for the Study of Women's Sexual Health, and a mother and a grandmother.
Yes, and really, truly amazing. And she's being very humble. She has done so much work in advancing women's health. So it is really an honor to have you on. So I'm so excited to have you on. So Sue, you've held so many leadership roles, including serving as a past president of ISSWSH. Can you share what initially drew you to women's sexual health and what kept you there when the field was still considered, let's say, fringe and not too many people knew about it?
Well, that's actually kind of a long story.
We have time. Let's go.
Okay. Well, my husband was a leading researcher and clinician in men's sexual health, erectile dysfunction really at the time. And when the New England Journal article, which was a seminal article, came out on sildenafil, which is Viagra, he was the first author, and people started to call him for care. I wasn't working in the field, but he always bounced ideas off me, and we talked about things. And when he realized that nobody really knew anything about women's sexual health issues other than psychological issues, he decided that we needed to do something. And so the two of us worked with somebody at his university at the time and set up a course of women's sexual health. And I sat in and helped out, and we did it again the second year. And he asked people, do you want to be a society? And they said, no. And he did it the third year. He said, do you want to be a society? They said, yes. So we started, as a grassroots organization. We didn't have any real funding. People paid to come to the meeting, but we didn't have any extra money. So I was the gopher. And I sat in and I listened, and I just soaked it all up as a sponge, but I wasn't working in the field. And then one day I woke up and I realized that my husband's dream, which was to have a biopsychosocial practice for all genders, for all sexual health issues, that his dream had become my dream. And we moved to California in 2007. And I thought I would just help out in the practice. And when we lived in the Boston area, I helped. I didn't work in the practice at all, but I helped him with educational programming and stuff because I was a teacher by trade. And I learned to write. I became a sexual medicine writer, a lot of weird stuff. But we moved to California, and next thing I knew, I was running clinical trials. I was learning a lot more medicine, but I was a menopausal woman. So I got to learn about menopause through my treatment. My husband came home one day and he said, it's a new questionnaire that we ask. We're asking our women patients, will you fill it out? And he goes, you've got FSD, female sexual dysfunction. Well, at the time I had low desire. I wasn't menopausal yet. And as I went through menopause, I was learning a lot about my body, and being married to somebody who understood the changes in the body. I had a hot flash one day, one hot flash. And I know people are jealous, but, I had access to care. Oh. And so I learned through him, and then I was working in the practice. And while I'm not a clinician and I can't provide patient care, because I've learned so much between ISSWSH and what we do in our practice, I can talk to providers and say, this is what we do. And that's been kind of fun. But I realized that I was very frustrated by the lack of education and the lack of conversations that not only healthcare providers were having, but women themselves were having. Women don't talk to their sisters, their mothers, their daughters about the changes in their body with menopause. Women think that Postmenopause is after menopause. Well, it may be after the vasomotor symptoms, the hot flashes and night sweats are gone, but you're in menopause until you die. And
Yeah.
the fact that women don't know this,
Yeah.
as a teacher, I said, we have to teach this information. I think that's really what made me so passionate. And then I did chair a lot of committees for ISSWSH, but being president of ISSWSH, I realized that I could be a role model for all those people who weren't physicians and thought they really couldn't help people as much because they weren't physicians. My favorite saying is that everyone said, I think out of the box. I said, no, my box is different than your box. And everybody has their own box. And we each in our own way. And Sadaf, you're helping the world by having this podcast. We can each in our own way help educate people, help improve their lives. You don't have to be a person who discovers a new drug. You don't have to be president of an organization, but we each in our own way can help women. And that really became my goal, to be able to help women in little ways and big ways.
Yeah, really, really amazing. I mean, Sue, people have no idea how much you've done, and you're in so many papers and published. I mean, really phenomenal work that you've done. And so, looking back, what do you think were moments in your career that shaped you the most on how you practice and advocate today?
Oh my gosh. I mean, I think going to the FDA when they had a
Oh,
hearing on
wow.
whether hypoactive sexual desire disorder was a medical problem or a made up problem. And my husband was one of the panelists for the FDA, but I was in the audience and I had a chance to be a speaker. You apply to be a speaker. And I talked about my experiences. I mean, that was huge to realize that so many people didn't want women to have control of their bodies. They were trying to tell women, this is made up. You don't have a real problem. And while it was hypoactive, it was HSDD. It's not menopause. It's the same idea that people don't have a right to tell someone else what they can and can't do with their body. And if you want to be treated, and if there's a medication, at the time there wasn't a medication, but if there's a medication that can help you, you have a right to make those choices. You just need informed decision. So that was a huge moment, I think, realizing that I could make a difference standing there at the podium at the FDA. And they did at the end vote that HSDD was, in fact, a real disease state. It wasn't made up by pharmaceutical companies. And then a couple of years later, I again got to go to the FDA when Addie was approved. Another big moment, I think, was being president of ISSWSH, because I had always had imposter syndrome, which so many women have. I remember it was like long before this. I was at an ISSWSH meeting. At the end of the meeting, probably about 12 people were asked to stay for an advisory board, nothing to do with this, which it was a company that was doing it. And my husband and I were flying home together. So I said, do you mind if I just sit in the back of the room? I won't disturb you because we'll leave together later. And they said, no problem. And in the middle of the meeting, they were trying to get some information that really only a researcher would know. And I said, excuse me, if you don't mind, I have that. I can give you that information right now. It's in my computer. It's something that I do all the time. And I realized I had a value that, I may not be a famous doctor, but I had a value. I had a knowledge base that somebody else didn't have. And so that was a huge thing for me to realize that I did. So that when I became president of ISSWSH, I realized I had no business having imposter syndrome, that I had value as a leader, as a mentor, as an educator. And that was huge for me. And then, of course, the little things like when my kids were born.
Yeah, no. I mean, you've had such an important impact. I mean, you've played such an important impact. I feel so fortunate to have been able to shadow Erwin just even those 2 days. And honestly, it's you run the show.
Well,
He just works there. He just
I'm
works
a magician at making things work out.
there.
That's I'm not the office manager, and I don't want to be the office
Yeah,
manager. I'm
no,
not
I
a
know.
provider. I don't give direct care to patients, but I work with patients a lot because I do a lot of education and stuff like that. But I'm kind of a magician, making sure that everything just flows and works. And that was really kind of my role with ISSWSH when we first started, before we had enough money to have a really good company helping us work out. That was my other role, being the magician, to make sure everything works out. We once, the International Society for Sexual Medicine had a journal that was owned by Nature, and when Nature didn't want to do what ISSM did, and there was a problem with it, the entire board resigned in 7 days. It was the last week of December in 2003, and the first week of January in 2004, the ISSM said, we're going to start our own journal that we're going to own. And invited all the people back, and they did. And it took 3 months to have a contract with a publisher. But in the meantime, I was blinding articles, sending them out to reviewers. So by the time we had the publisher all set, we were ready, and we actually published the first journal in August of 2004. So I'm not the editor. I didn't want to be the editor, but I have been involved in so many of these things. It's kind of cool. I actually gave a lecture at the AUA on the history of sexual medicine, the modern history, and I realized that other than Alfred Kinsey's first book on men with sex, which was published the year before I was born, every other major milestone in men's and women's sexual health has happened in my lifetime, and that's pretty incredible.
Yeah. Yeah, that is really amazing. So for listeners who may not know, what is ISSWSH and why is its work so critical now, especially for midlife women?
So ISSWSH, the International Society for Study of Women's Sexual Health, and unlike most societies that are medical societies that have have MDs, and then other people can join, this society was built from the ground up to have equal import for all of its members, whether an MD, a PhD, a physician assistant, a nurse practitioner, a sociologist, a basic scientist, a clinical researcher like myself, or an educator. We all have equal import. And because without everyone coming to the table, we weren't able to really move the field forward. I mean, if you think about it, this is 1998 that we first identified that women wanted something other than therapy.
Or a glass of wine.
Yeah, a glass of wine, a piece of chocolate, leave your kids at home and go away for the weekend. Right. I always say, don't you think she would have tried that already before she came to your office, doc? People are stupid. One of my pet peeves is if you don't know, say to your patient, I don't know, I'm going to find out about it. I don't know, I'm going to refer you. I don't know, let's schedule another appointment so we can talk about it. That's okay. But to say, oh, there's nothing that can be done just because you don't know, we live in the age of the internet. And yes, half the stuff in the internet is wrong, but half of it is right. And if you have half a brain, you should be able to figure out what's legitimate and what's not. So that's one of my many pet peeves. For 20 years, because of the Women's Health Initiative, I'm sorry, I'm digressing. I was telling you about ISSWSH. So what's cool about ISSWSH is that when we go to meetings, we have a symposium, and we'll have a biologic provider, we'll have a physical therapist, a doctor, or a nurse practitioner, we'll have a sex therapist, all on the same symposium talking about the same topic. Because we as women do not live isolated. Our brains are attached to our bodies. Our muscles are attached to our bones, and any one thing that goes wrong affects all the different systems. And so ISSWSH was built from the ground up to understand all of that. And because there was such a paucity of data, we knew very little. By all of us working together, we were able to fast forward the field. It's less than 30 years old. The field of women's sexual health is anything other than mental health. Less than 30 years old, and we know so much stuff. It's remarkable. And it's because people aren't competing with each other to get the next great discovery. People are working together to move forward to get the next great discovery. But I was starting to say one of the biggest problems we have is the Women's Health Initiative that was published 25 years ago made women scared of hormones. And when you're menopausal, basically your body has shut down, is not making the hormones it did. And please remember, when man evolved 200 years ago, we didn't live long enough to be in menopause for more than 2 years. We're living so much longer these days. And for 2 decades, gynecologists weren't taught about how to do hormone treatments because they thought it was a no-no. And so ISSWSH has been teaching about menopause management and proper use of hormones for all of these years. And so it's so wonderful to have a place where, while we may not all think exactly alike, we all think in the same direction. And we all want what's best for women. And it's only now that the FDA removed the boxed warning on hormones that people are starting to talk about menopause management with hormones, which is so sad because women have suffered. Women have died because they haven't been on hormones. I always say, I'm proud of my age. I'm 76 years old. And people always say, oh my God, you have so much energy and, you look so much younger. Well, good genes. I mean, I don't look young. I'm an older woman, but I have good genes. But I've also been on menopause management for, 20 years. And that's allowed me to keep my brain functioning and my body functioning. and allows me to be passionate about teaching other women because I want other women to have an opportunity to feel good. And while we're getting older, we aren't old.
Yeah,
So
absolutely. I love all that. And so, during your time as president, what shifts or progress are you most proud of within the field of women's sexual health?
well, as a society, we developed a strategic plan for the first time, and so I was really proud of that because it meant that our society had grown up. But during my presidency, what shifts? Oh my gosh, that's a hard question because I'd have to think about, I mean, there were no new drugs, but I think the fact that we had many processes of care, some while I was president elect, some while I was president, we now have process of care for hypoactive sexual desire disorder, one for just identification of sexual health disorders, and that actually was before I moved into the executive committee. We have a process of care for persistent genital arousal disorder, genital pelvic dystocia, and that's something that is so devastating to have that out there and have it published open access, which means anybody can download it and take it to their doctor. I mean, that was a huge step. That
Yeah,
was when I was
yeah,
president elect, I believe. Well, it's hard. It's hard to think. We just did a lot of education courses. I think one of the big things that happened during my presidency is ISSWSH developed a series of online courses in addition to our in-person fall course, and that
yeah.
was huge because it allowed people to watch synchronously or asynchronously and around the world. That was a huge step, and I'm so proud of the education committee that put that together. Now we have several courses that go on each year. It's huge because if we aren't providing this educational content to clinicians, they're not getting it during their residencies. They really aren't, and so I'm just very proud of that. But in terms of externally from outside of ISSWSH, I think just the fact that people are continuing to do research, even though there's no funding from the government, there's no real funding from private industry, but people are still managing to figure out how to do research, and that's so important. As a society, we give out research grants. I think during my presidency, we gave out like $70,000 of grants one year, which doesn't sound like a lot of money to you, but for a young researcher to get a $7,500 or a $5,000 grant, it can make the difference
Yeah.
between doing the research and not doing the research. So
Right. Absolutely. Absolutely. And so, where do you feel we've made real progress in recognizing sexual health as part of the overall health? And where do you think we're still falling short?
well, I think a big thing was that the ICD-11, International Classification of Diseases 11th revision, which is not yet being used in the United States, but is being used elsewhere. That's the coding for diagnosis that the clinician has to use to have the insurance pay, or whether your insurance or not. But that's the coding of your diagnosis. And so many of the women's sexual health diagnoses were mental health diagnoses. But in the 11th revision, there was a full chapter on sexual medicine, and we have
Mm,
biologic codes for the first time for so many things. And that's a huge step forward
huge. Yeah.
because it allows people to have these disorders and it be recognized that it's a physical change. And if it's a physical change, then at that point you can choose whether you want to have sex therapy or medication to treat it, or both. A lot of things, your brain is neuroplastic, and so a lot of things can change from either medication or from therapy. But if you have pain, obviously we need to figure out what's the cause of the pain and treat that. But to be able to have diagnoses that are now appropriate, huge, huge, huge. And I cannot wait until the United States insurance companies adopt it, because until they adopt it, our EMR systems won't use it, which means we can't use those codes yet effectively.
Yeah, and so it validates their symptoms, right? And it's
Exactly.
saying that it matters and that insurance will actually cover it, and that this is something that should be treated. So absolutely, you're so right. Such a makes a huge difference.
Yeah.
So midlife is when women often feel most dismissed, especially when it comes to libido, pain, and desire. What do you think clinicians most misunderstand about sexual health in perimenopause and menopause?
I think they misunderstand the ability to, well, it's not they misunderstand, they don't listen to their patients.
Yeah.
If they don't see something wrong, you wind up getting gaslit. They think, oh, it's all in your head. Well, it may be in your brain because there are biologic changes that can happen in your brain. But a lot of times people have problems with their vulva region, the vestibule, which is just between the labia minora and the vagina. In between is an area called the vestibule that you really don't see, but it can cause a lot of problems. It can get very inflamed if your hormones are not normalized. You can get neuroproliferative vestibulodynia, and these things need to be treated, or you're in constant pain, or you're in pain when you try for penetration. And if the clinician doesn't understand that, and he or she doesn't, know how to examine what to do for neuroproliferative, for instance, it's a diagnosis of exclusion. You have to rule everything else out. Too many times, doctor doesn't see anything wrong, and he just says, "Oh, nothing's wrong. It's all in your head," and that isn't fair. A woman knows her body. Even if she doesn't know the names of her body parts, even if she says it hurts down there, find out what down there means. I mean, that's another pet peeve of mine, that we don't raise our children to use proper names. The vajayjay doesn't help us. We still don't know. You're talking about the vagina, the vestibule, the vulva, the clitoris, down there. What does that mean? But as a physician or nurse practitioner, physician assistant, you should be helping your patient understand their body parts, helping them see that, even if it's just holding a mirror there. And if you can't see what's wrong, don't dismiss your patient. It just means you haven't figured out what's wrong. And maybe you need to look it up. Maybe you need to refer to a specialist. But don't ever tell a person it's all in your head until you have absolute proof that it's a psychological problem and not biological. Usually there are biologic and psychological problems that go together. So, we need to treat both.
Absolutely. Absolutely. So what are some myths about sex after menopause that you wish we would just get rid of?
Well, I've had people ask me, how old is too old to have sex?
Oh my goodness.
Seriously. And the reality is, if your cardiologist says it's too dangerous for you to have sex, or it's too dangerous, you can't climb up 3 flights of stairs without being really short of breath, those are the only reasons you shouldn't have sex. Now, you can choose not to have sex, but the idea that you can't have it. So as a menopausal woman, sex is going to be very uncomfortable for most people if they're not on hormone therapy. There are some people that actually they seem to get enough, but that's rare. So the idea that you're going back to the idea that post-menopause means menopause is over. No, you're in menopause all your life. Menopause means your ovaries have stopped working. It's not making testosterone. It's not making estradiol. And if you don't replace it, eventually your labia, you're going to shrivel up. Your clitoris is going to get smaller, and sex is going to be painful. So it's your decision. Do you want to live with your partner like brother and sister, which is your choice? Lots of people do that. Yeah. Or do you want to be able to be sexual? And just because you didn't start on hormones the day you started menopause, there are ways to treat older women. There's a lot of information out there that says you can't start hormones later in life. The fact is that I'm not going to say you can for everybody, but if done properly, if it's monitored, and I'm going to go backwards a minute. Gynecologists started giving estradiol back in the 1960s when Premarin was invented. And Premarin is pregnant mare urine. So it's not the same chemicals in your body, and it works to help, but you can't measure it because it's not the same as in the body. So they never measured blood tests. Urologists gave testosterone, and they wanted to make sure that they weren't giving too much testosterone. So they're used to measuring blood tests. So when this field started, and I will remind you, as my husband essentially started the field, he's a urologist. So he believes in blood tests. Well, now we don't use the pregnant mare urine anymore. We have bioidentical. It means the estradiol we use now is the same chemical as in your body. So we can measure how much is in the body of the estradiol, of the progesterone, which you need if you have a uterus, of the testosterone. And so there are ways for older women to have menopause management as long as it's monitored. That's even true for some women who have cancer, but that's on a case-by-case basis. I'm never going to say it's totally safe for people who are post a cancer diagnosis to have hormones, but there are ways of doing it for the appropriate candidate. So to think that you're 70, you've been having painful sex the last 20 years, you meet a new partner and you want to have sex now, there are clinicians that can help you. You don't have to retire if you don't want to. Your choice.
Right. 100%. I love that. And I'm glad you say that, because so many people will think that, menopause means abstinence, or that they can't have sex anymore. And that's not what it means at all, right?
I'm still having sex.
Yeah. Yeah, absolutely. Absolutely. And that's fantastic. So, when a patient says, I just don't feel like myself anymore, what questions should a good clinician be asking beyond labs?
Well, you really want to know what they mean by that. Are they having pain? Are they having lack of desire? And it's interesting is that some of those things will cause relationship issues.
Yeah.
Are they having persistent genital arousal disorder where you feel like you're constantly aroused, but there's nothing sexual about it? Or it may feel like cutting or burning. I mean, so you want to find out what are the symptoms that you're having right now that you feel like you don't feel like yourself. And with the hormones, I mean, while we don't have randomized placebo-controlled clinical trials to show that using hormones will help you maintain your cognitive abilities and your memory. So I'm not going to say definitively it works, but based on expert opinion, it appears that it helps with those things. So really,
Yeah.
well, if you don't feel like yourself, what does that mean to you?
Yeah. Yeah. 100%. And so there's often fear and confusion around treatments like hormones, testosterone, vaginal estrogen, non hormonal options. How do you approach shared decision making in ways that empower patients?
I think the number one thing is education because people are fearful of hormones. And if we can show them the data that in their particular case there's nothing to fear, or in their particular case these are the potential risks that you're taking. I mean, we always have to talk about risk benefit, and then it's ultimately the patient's choice whether the risk is the benefit is worth the risk. I had a patient once say to me, who's called me on the phone, and she says, I don't understand. Dr. Goldstein prescribed hormone for me and it's illegal. I said, nothing's been prescribed for you that's illegal. She says, well, my Medicare won't pay for it. I said, well, that's just your insurance is cheaping out. That has nothing to do whether something's legal or illegal. So it's interesting how people interpret things. I can't remember what you asked me now.
Yeah. Just basically about shared decision making that empowers patients.
As I say, education, risk benefit, and then it's up to them. And at any given time, a patient can change their mind. I don't want to do this anymore, or I'm ready to try now. I wasn't ready to try 6 months ago. It's a different time when we were, well, not when you were a child. When I was a child, it was the male doctor, and he told you what to do, and mom listened to what he said. And that's not what we believe in today. A good clinician, as you said, shared decision making. This is all of the information. What do you want? What do you feel comfortable doing? And that's the way you should, approach it.
Yeah.
But you can't do that without giving all of the information, the risks and the benefits, so that they can make an informed decision.
100%. So, what does truly patient centered sexual health care look like in practice? I feel like your practice does that, right? Patient
Well, I
centered.
hope so.
Yeah. I mean,
Yeah,
that's what it does.
so in our office, we're a biopsychosocial practice. So we have a full-time sex therapist, we have a physician, we have 3 nurse practitioners. So when you come in as a new patient, you meet our sex therapist. She's not going to do sex therapy on you. She's going to assess whether you might benefit from that. If there are psychological issues that may be, dominating what's going on versus the biologic. And sometimes people are convinced that they have, like a young healthy man, as an example, may be convinced that he must have his AD must be psychologic because he's buff and he's strong, and the fact is that he may have a biologic problem, a blood vessel that got ruptured, got basically destroyed when he was playing soccer and someone kicked him in the groin or something. And I just use that as an easy example. But it's nice to have a sex therapist to be able to sort of figure out what's going on there. And then she talks to my husband is the urologist, and so it's a combined assessment, the biologic and the psychologic. And to me, that's the best healthcare. Not everybody can have a sex therapist in their office. We used to have a physical therapist in our office, and now we don't. It just didn't work. But we refer to physical therapy all the time. So any clinician who's doing sexual medicine needs to have basically on speed dial a couple of sex therapists, a couple of physical therapists, people that they trust, and people who share the same language, so they don't have to spend 20 minutes explaining what they need or want, but understand each other. And that makes life so much better for the patient, because ultimately we are all in the same business of helping patients. So anything we can do to help them in a better way is going to be better for them.
Yeah, absolutely. So you've been so involved in education. What do you think is missing from medical and healthcare training when it comes to sexual health? I know there's so many things, right?
When you're in medical school and they teach you sexual medicine, sexual health, you know what they're actually doing? They're teaching you how to do a sexual health interview focused on sexually transmitted infections. And they're teaching you how to treat STIs. There really is very little attention. Sometimes in the biochemistry class, there may be some discussion about how sildenafil works, which is Viagra. Um, but there's very, very little done in medical school. And there is a group called AMSA, American Medical Students Association, and they reach out to different clinicians with different specialties, and they say, you know what, we want some sexual medicine stuff. And so they'll get an hour lecture on sexual medicine, and people from all over the country who are part of AMSA can log in. There's a group called Tight Lipped, which is a grassroots organization of young women with vulvodynia or vestibulodynia who are working to get this information into OBGYN residencies. What I tell my patients all the time, instead of being angry with your gynecologist, when he or she went to residency, she really had to do 2 residencies at once, one in obstetrics to deliver babies and one in gynecology. And the only thing they have in common are the same reproductive organs. And there just wasn't time to learn anything else. So instead of being angry, go back and teach your clinician what you learned from us or what you learned from somebody else who's a sexual medicine physician. So there's very little available. But ISSWSH has put together modules for providers, for practitioners that we have opened up to the OBGYN residents through Tight Lipped. So, we're able to help with some of that education. And then for everybody else, they're, welcome to, take these various courses and learn, because it just isn't time. Every time you put something into a medical school curriculum, you essentially have to take something else out. And same with residency. So what do you take out?
Yeah. Yeah, 100%. When I was a med student up at Michigan State, I feel like, the only thing we learned was a little bit about the Masters and Johnson, linear model, and that was about it. I don't remember anything. And then we also learned about erections, sympathetic, parasympathetic, but that was it. I mean, there's nothing on menopause. And actually, yesterday, I was able to give a lecture to Michigan State OBGYN residents, and I used the ISSWSH slide deck. I used a lot of the slides from ISSWSH, and I had taken some pictures from at ISSWSH. I had what Dr. Goldstein had done about orgasm and dividing into 3 phases. I talked about that. I talked about the process of care for PGAD and for hypoactive sexual desire disorder and all of these things that I learned at ISSWSH. And they enjoyed it so much, they asked me to come back and talk to them again. But, it's all because of all the work that ISSWSH has done and all the research that you've put out that, clinicians are able to then teach others, which is so important.
I'm so glad. I mean, that's what the slide set is for, so that you don't have to reinvent the wheel. You can use those to teach. And I'm so happy that not only that you used all those resources, but they were so happy that they wanted you to come back and talk more. That's fabulous, because, they're sponges and they want to learn it. And
they do.
The reality is that sexual medicine is fun. It's
Yeah.
not boring. It's fun.
No, it's the best. It's the best. I love it. So if you could redesign sexual health education for clinicians, what would be some of your absolutely non-negotiables?
Well, I mean, as you said, they knew a little bit of erectile dysfunction, but I think there's such a large number of men with erectile dysfunction. They have to understand, basically how erections work. They have to understand how hormones affect women, both when young women are on combined oral contraceptives that are hormonally based and women going through menopause. I think those are essentials. And then low desire for women is a low hanging fruit. It's, it's easy to treat from that point of view. So that's important. I think, when you start getting to arousal and orgasm stuff, it gets more complicated. But the fact is that the medications that treat women for HSDD, the clinical trials have shown they also improve arousal and orgasm. But if you have an orgasm problem alone, that's a totally different thing. That's more complicated. The other thing I think that would be nice for them to learn, treating PGAD, GPD is very complicated. There are a lot of reasons why people present with GPD that are ignored by clinicians. If someone has a problem that normally is treated by XYZ, and XYZ has done nothing, don't give them XYZ again. Think out of the box. They may have their pain in their testicles or in their clitoris, but it doesn't mean that the pain is generating from the testicle and clitoris. And, being able to understand all of the treatments gets complicated. But be able to understand that there are, 3 nerves that are innervating that area, and to look elsewhere, to look in the cauda equina. I think the bottom line is not to dismiss the patient. If you can't figure out, it goes back to what I said at the beginning, if you can't figure out why they're having the pain, the burning sensation, don't assume that they're crazy, and try to figure out what else it could be. So I think the biggest thing that we need for medical students and residents is curiosity, to be able to go beyond what they've learned in the book, that A means Z and B means D or whatever. And if it doesn't work that way, to be curious enough to investigate and to know that there are other possibilities. My husband's an engineer as an undergrad, and that's part of why he's done so much of this investigation. When he started in urology, nobody knew how an erection works. Now we have full understanding of how an erection works. Because he's an engineer, he wants to know, well, if I do this, what happens to this? And why is this occurring in the human body? And so let's investigate. So I would want to inspire passion and a desire to learn more about sexual medicine. Give them a taste, and then tell them to run for it, and look for more stuff to do.
I mean, Erwin, and you both are so amazing. Erwin is just so amazing in all the research that he's done, and with all the different when he talks about the different regions, I never, I didn't learn that. That was not something that I learned, but now I can see how all of that plays into effect, right? Like if it's not region 1, then you look at region 2, region 3, region 4, region 5, and that, for people that may not know what I'm talking about, it's just basically trying to figure out where let's say somebody's pain starts out. And like what Sue was saying, that if it's not in the end organ, then you have to look up higher, and you keep looking up higher until you figure out where that pain is originating from. And, that is not something that we learn at all. And it's only through ISSWSH that, you gain this type of knowledge. So it's just been so amazing, and so much knowledge.
It's when the consensus panel put together the PGAD paper, they realized, I don't even know how it came to be, but they realized that breaking it into regions worked. And then we realized that using the regions works for everything, for all genders, for most every sexual health concern. It's just a very logical, reasonable way of doing an assessment, because it's methodical. You start with region 1, region 2, just go on. And it's just a smart way of doing it.
It is. It makes so much sense. And you don't think about it until somebody puts it down on paper and shows you, and you're like, oh, of course, this makes complete sense. So, what excites you most about the future of women's sexual health research and care?
Wow. I think that what excites me most is that there's so many young people who've come to ISSWSH, who are involved in research projects. And even though a lot of those research projects are review papers, it's turning them on. I think we have a future that we're going to have a lot of really passionate clinicians caring for people. And that is so exciting to know that. And we had 5 people from six people from our office, young people from our office, who presented at ISSWSH. I mean, I'm so proud of them. And whether they all stay in sexual medicine in the future, I have no idea, but it doesn't matter. If one of them goes into sexual medicine, it's a winner. I think the first time I've tuned into a committee meeting for ISSWSH and saw a committee member who had once been a medical student doing an elective in our office when she was in med school, and now she's serving on a committee at ISSWSH. That is so exciting. She learned her passion sitting in our office, and now she's living that. I think that's the best thing, that we have so many people that are truly interested, and that really bodes well for the future.
Yeah, absolutely. How do you think we can create safer spaces for women to talk about sex without shame, both in exam rooms and in society?
I mean, I think a lot of it depends on the clinicians. The research shows that people are afraid to start the conversation about sexual health for embarrassing their doctor, or I'm saying doctor, but it could be a nurse practitioner, PA. But I think doctors tend to be more shy away from sexual medicine than the advanced practice providers. But the practitioner needs to realize that the patient may have an issue. It's very simple ways of starting a conversation. I'm a menopausal woman. Mary, you're a menopausal woman. Many women in menopause experience pain with sex. Is that happening to you? Now, she can answer yes or no. But you've told her that what she's experiencing is normal, that this is a safe space to talk about it, and that you're going to do something about it. So if she says yes, Mary, that's such an important topic. And today we're having our well visit. So let's schedule a follow up visit so we can talk about the pain. Or if she says no, well, then why not do an open ended? Well, because it was so painful 2 years ago that I haven't had sex in 2 years. Um, Making statements that allow a person to feel safe and respected and listened to. That ubiquity statement is really a great opener. And then remembering to ask open ended questions so that they can explain what's going on.
I love that. I love those questions that you said because I think that's so, so important to leave the door open so people can actually ask you questions. Some of the people that come and find me in my practice, it's actually their husbands that find me. And it's because their wife has been having pain with sex for so long and hasn't, been being intimate with them that they are trying to find a solution. And so they actually find me that way. And I would say like about half the women in my office, they come to me because they're having pain with sex and they were just too embarrassed to find somebody themselves. And actually it's their partner that ends up finding me. So yeah, I think it's really important for clinicians to feel comfortable talking about sex.
And that same community, you'll find patients that are having pain with sex and they've had it for so long, they think it's normal. And
Yes.
that is so sad.
Yes, yes, 100%. And, I was just in one of our other podcast recordings. I feel that, women have been so accustomed to pain their whole lives that they just expect it, right? Like from the
Mm-hmm.
time that they have their periods and their menses to endometriosis and fibroids and childbirth, then they get into perimenopause and menopause, and they just expect pain their whole life that they just think it's normal. And you're absolutely right. We're not
I'll
doing a good
also
job.
remind you if a man has ED, he'll spend his last penny to buy pills. A woman, are my kids clothed and fed? Did I buy the Christmas presents or whatever holiday? A woman takes care of herself last so often. And her health care may be that piece that's last. She just sort of subrogates everything. I have no interest in sex and I'm just, I'm not going to worry about it versus I have no interest in sex. And I think that's wrong. I think I should have it. So I'm going to go to the doctor. They just push it down or the pain and they live with it. And that is so sad because we have equal import to men. If
Absolutely.
they enjoy
Absolutely.
pleasurable, pain-free sex, we should enjoy pleasurable, pain-free sex.
100%.
Um,
100%. And
and it's not fair otherwise.
I feel like it's almost seen as kind of like a luxury, right? Like for women to be able
Yes.
to have sex without pain, like it's just like, oh, well, like just what you said, right? It's like the last thing that women think about is themselves. And sex, forget it. It's kind of like, oh, that is kind of like a nice to have, but I don't really need it, right? Like if I'm not having sex, it's okay. It would have been nice, but it's okay if it's not happening.
So there's a thing called gray divorce, older couples that
Mm,
are divorced.
yes.
And my thought, and I don't mean to be gross, but his half limp penis is looking for a lubricated vagina. They're both aging. She's not on hormones. He's not on a PD-5 yet, or he is, and it's not all that hard. And I will tell you that a firm penis is easier to go into an unlubricated vagina than a soft one. And so wind up divorcing, or they wind up being living like brother and sister. And then when he leaves the socks on the living room floor, it makes her crazy. Whereas if you're having sex, yes, he leaves his socks on the living room floor, I'll pick them up. Sex is a great equalizer because it just sort of it's a de-stressor. We know that. And it just takes all away that little thing. So when you're having a good sexual relationship, and not that sex is the be all and end all, but when you're in a relationship and you're having good sexual experiences with your partner, it really helps keep that relationship alive and growing. And I'm assuming that your partner's not abusive or any of those things, but having sex versus not having sex makes a difference in the relationship and the couple.
I love that. I love that. And I think, you're absolutely right, right? Because if you have a good, loving, healthy, safe sexual relationship, the little things don't bother you because it's not a big deal, right?
Right.
Because everything else is fine and everything else is going great. But like you said, is that, and I always feel like whatever is going on inside of the bedroom is also going on outside of the bedroom. And so if you're,
Oh, that's a great way to say that stuff. I love
yeah.
that.
Yeah, because like if you're not talking about sex, you're not talking about all of the issues, you're probably not talking about all of the other issues that are happening in your life as well, right? So then more and more people pull away And then that's how we, start to have these sexless marriages. And then, like you said, it results in the great divorce because there's so many, untalked about issues in that relationship that people don't even know each other anymore.
Yeah, sad.
Yeah, absolutely. So what do you hope ISSWSH continues to prioritize in the coming years?
I would love them to continue to prioritize research because there aren't research dollars elsewhere. And if we stop research, the field dies.
Yeah.
So that's important. We're an international society, and at one point we had a lot more non-North Americans, and so I know that this is a priority of our leadership to continue to expand our membership around the world. But the other piece with that is also to expand education, and we've done teaching in a lot of other places in the world, and we'll continue to do that. And so I'm so proud of our immediate past president, Linda Vignozzi, our current president, Sally McFedrin, our president-elect, Tammy Rowan. They're all very involved in getting more education to providers so that people in other parts of the world with no access to education can have enough education to help the patients in those communities. We can't be everywhere, but we can do our best to teach people elsewhere to care for people at other places. So to me, those are the things that are really most important.
Yeah. Yeah, absolutely. So for the woman listening who feels, let's say, invisible or too complicated, what do you want her to know?
You're not too complicated. We just need to start one thing at a time. For a long time, people used to say, well, men were straightforward and women were complicated when it came to sexual health. And what I always say is complicated sexual problems in men are complicated, and complicated sexual problems in women are complicated. Simple ones in men are simple, and simple ones in women are simple. It may feel complicated to you, but if you go to somebody who understands sexual medicine and knows how to deal with each piece, it may be that all the problems you're experiencing are really from one pathology, one problem that's causing all of it, or maybe you have multiple things. That's okay. I have HSDD and I'm menopause, so I have two different things I'm dealing with, and I'm fine because I'm having treatment. Don't feel like you can't try to get help because you're too complicated, because then you'll never get help. Just start, and what's the thing that's most distressing for you? Start with that, and when that's treated effectively, then go to the next thing, or start with what's maybe the easiest thing to treat and then go to the next thing. But don't give up. You owe yourself, the opportunity to have pain-free, pleasurable sexual relations, if that's what you want. And if it's not sex, it's just because you're experiencing pain or you're not feeling good about yourself for other reasons that have to do with sexual health. Don't give up on yourself, because if you do, nobody else is going to help you.
100%. Yeah.
Fight for yourself.
Absolutely. I love that. And for the clinician listening who wants to do better, where should they start?
Well, start with ISSWSH, ISSWSH.org. You can, go on, do online courses, become a member. And by the way, for those people who are trainees, membership is free. But, come to our meetings, come to our courses. You can also do preceptorships in my office, preceptorships with some other people. But make sure that if you're trying to learn, you're learning from people who actually have expertise, and not somebody who is just a podcaster. Is not, and I'm not talking about you, but there are podcasters that don't necessarily have the expertise. Find someone that can help you. But ISSWSH is absolutely the number one place to go to learn and become better at what you do, no matter what your field of medicine is. We have radiation oncologists. We have all sorts of things that you wouldn't think would be part of sexual medicine, but actually play a role in sexual health care for women. So come find us.
100%. Yeah, 100%. I mean, I've learned so much, and I think that I just feel sad that I didn't discover ISSWSH earlier on in my life, but here I am now. But it's been so amazing, right?
You're still young, and you have so many years in front of you to practice. Think about how many thousands of women you are going to help in the future because of what you learned over the last few years at ISSWSH. It's just fantastic.
Yeah. Yeah, I know. I love it. It's amazing. So for all of those people that are listening and watching and thinking, wow, Sue is so amazing. I just can't believe, what an amazing resource she is. How can they get in touch with you? How can they reach out to your practice, San Diego Sexual Medicine? How can they make an appointment?
Well, thank you for all the compliments. I appreciate that. I'm not sure how worthy I am. Our practice phone number is 619 265 8865. And you can call there. If you want to speak to me, just ask for me. If you want to become a patient, everybody starts off with a 10-minute courtesy call. It's a 10-minute conversation with either my husband, Dr. Goldstein, or a nurse practitioner, Mia Newstein, and they'll get enough information from you to know what we would need to do should you choose to come in as a new patient. There's no obligation to be a patient. There's no cost for the 10-minute call. It's a fact-finding mission for you and for us, so that if you do come in, we can better care for you. So again, 619-265-8865 if you want to make a courtesy call. And if you want to see more about us, we have a very large website. It's san diego sexual medicine.com, or you can do a shortcut, which is SDSM, our initials, sdsm.info. And we have hundreds of many pages on our website, and you can learn a little more about what we do and who we are. And thank you for letting me plug our practice.
Of course. And, for all those people that are listening and watching, all you have to do is Google Dr. Erwin Goldstein, Google Sue Goldstein. You will see their names on so many research articles and chapters and books. They are the real, what do they call it? The godfather and godmother of sexual medicine. Just so amazing, the amount of work you've done in such little time. It's just really phenomenal. So thank you so much for all that you've done. We all appreciate, and we all benefit from it. So that's truly what's amazing. And well, we are done here, and it's been real and really intimate. So if you have any questions about your health, make sure you go speak with your healthcare provider. And if you are looking for somebody that can deal with sexual medicine, you can go to ISSWSH.org and look for an ISSWSH fellow and provider in your state, and you can get help there. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.